Hi, my name is Staci Carr.
And I'm Carol Schall, and we're with Virginia Commonwealth University Autism Center for Excellence. We're here today to talk about mental health diagnoses for individuals with ASD.
First, we're going to talk about what other diagnoses might be going on with children and young adults and adults with autism. And there might be some co-occurring diagnoses that happen that may or may not be diagnosed, but symptoms may arise. And some of those diagnoses include things such as attention deficit hyperactivity disorder, anxiety, OCD, depression, ODD, bipolar. There's a whole host of mental health issues that can also kind of mask some of the symptoms of autism. Some of these overlaps in symptoms make it extremely difficult for physicians to parse out which is either the mental health diagnosis or the autism diagnosis. So if you can take a minute to reflect about the symptoms of autism, and then think about what we know about co-occurring mental health diagnoses. So Carol, what are some of the symptoms of autism that we think about when we think about those that really impact the functioning of an individual?
Well, the first one that comes to mind really is communication impacts. And when we talk about autism, we have communication impacts that range from those who don't use words to those who use a lot of words, but use them in odd ways.
Absolutely. And so when we think about mental health diagnoses, we think about, sometimes with depression, a lot of people have, they tend to be withdrawal, have some of that not wanting to talk to other people, or with anxiety, there's maybe sometimes over explaining, talking through things. What other symptoms can you think of?
Well, the other big symptom area is social interaction. And folks on the autism spectrum have extreme difficulty having appropriate ways to interact with others, initiating interaction, having kind of a graceful give and take with interaction, and sometimes even appearing to be difficult because of their own difficulties with interaction.
And again, those are some of the same things we see with people who have a mental health diagnosis of depression, compulsions, anxiety, depression, OCD. So we see that kind of inability to manage their own emotions, how to interact with someone in an appropriate way. And so when you think about autism and these mental health diagnoses, we really see a very difficult way of deciding which is the autism and which is the mental health diagnosis.
Staci, that even is very present when we look at those last two on the slide on the right-hand side.
Absolutely.
Obsessions and compulsions. I mean, one of the hallmark characteristics of autism is really wanting things to be organized in the same way, to be lined up, and they can appear to be very obsessive and compulsive about the organization of their day, their overall behavioral adjustment. That can really impact the person and also confuse the whole issue of whether or not there might be mental health diagnoses in addition to the autism symptoms.
So clearly that would be very concerning for a parent if they're not sure if their child is on the autism spectrum and they see some of these obsessions and compulsions. They might not know, is that an OCD tendency, or is there other things going on that may lead to an autism diagnosis?
Right.
So we're going to be talking about comorbidity today, and that's the presence of one or more additional diseases or disorders that occur with a primary disease or disorder. Go ahead.
I was going to say, this is a medical term, and
Right.
So please know that we don't think of autism as a disease, and the fact that people struggle indicates that there is some level of disorder, but we always think of people with autism as people first.
Absolutely.
And a lot of times individuals with autism present an array of characteristics that actually are not just, quote, diseased or disordered. So we don't want you to take this language as if we're saying having an autism spectrum disorder is an extremely negative experience. Instead, we're using a medical term and using the definition of that medical term, using those medical terms.
Sometimes when I talk to families or practitioners, I use co-occurring diagnosis as opposed to comorbidity or disease or disability. And that seems to help too. So when we think about the three big categories of disorders, we think about anxiety and depression, which we see so much of, especially as young children morph into teenagers and adolescents. We see habit disorders, and those are the OCD, obsessions and compulsions that Carol spoke of, and then the disruptive disorders. And these are the things that generally get children in trouble at school, so the acting out, the outbursts, the inability to sit still, perhaps hyperactivity. So those are some of the things that we're going to be talking about. So we're going to start with research. So we know that people with autism have an increased risk of developing a psychiatric disorder. And in fact, it's estimated that about 80% of persons with autism experience a mental health problem at some point in their life. And what we know is that depression is the most common. And when we think about depression and the autism spectrum, oftentimes depression really hits those folks who are more verbal, who have more social ability, when they see that they are not interacting quite like their peers, maybe getting into trouble at school, having a hard time negotiating things at work, and so forth. Mm-hmm. Another study showed that children with and without intellectual disability as well also have an increased risk of anxiety disorders at 57%, specific phobias. So those are things that are not just generalized anxiety, but specific to maybe dogs or elevators or those sorts of things.
Or even sounds.
Exactly, yeah. Sounds. Lawnmowers is a big one.
Lawnmowers, the fire alarm at school.
Oh, absolutely.
Huge trigger for an anxiety reaction.
And then with attention deficit hyperactivity disorder, 60%. Also, OCD is twice as likely in folks with a higher IQ. And when we think about the specific phobias that happen, when children get older and are into adulthood, what we see is agoraphobia being the major diagnoses. And agoraphobia is the wanting to stay at home, fear of being outside, being in public with other people, and we see that a lot with adults. Another diagnosis is bipolar disorder. And one of these, when we think about bipolar disorder, there is the major depressive disorder, and that is not as prevalent as the bipolar disorder. And bipolar disorder is about 75% of the sample of people with autism and co-occurring mood disorder. So when we talk about bipolar, that's the very high highs and very low lows. And I imagine for teachers or family members, and when they see these cycles of behaviors, they might think that's caused of the autism or perhaps some sort of trigger that has happened. So again, this is an area where it might be hard to parse out whether it's a diagnosable bipolar disorder. We already said that depression is one of the biggest co-occurring diagnoses, and research has shown that at least 10% of children with autism had one major depressive major episode of depression in their lifetime. And so that's just those major depressive episodes. At least 11 to 25% have that sub-threshold kind of depression, sadness that might not render a depression diagnosis, but that sub-level of that malice sort of sad feeling. Bipolar disorder, another study showed that folks with what was formerly called Asperger syndrome, we have to say that now, it's all lumped into autism, but those formerly known as Asperger syndrome, adults with AS are 6 to 21% more likely to have a bipolar disorder. And symptoms usually start in adolescence. And they see this sort of atypical presentation. And again, like I said before, it's, those high highs and low lows. But we don't know that if it's just, joyous occasion, elation, feeling very happy about something, or they're irritable because of something going on at school or at home. But we see that there's this very big discrepancy between those highs and lows. So I'm going to plug behavior data collection right now, because this is something very important to make sure that we're collecting data on a daily basis about a person's behaviors, and anecdotal notes about things that you may see, whether setting events, things that happened prior to a behavior occurring, or maybe even things that have happened on the way to school or at work or at home, because that can really help physicians figure out what is going on. Autism and OCD, we know that folks with OCD are 2 times likely to have an autism diagnosis as well. And, like Carol said, having those obsessions and compulsions, really wanting to have things in their order, making sure that their day is set in a certain way, having control of their schedule, and having anyone try to change their schedule can really look like a very obsessive way of thinking. Disruptive behaviors in autism are things like oppositional defiant disorder, conduct disorder, and ADHD. And these are, again, those behaviors that tend to get kids in the most trouble at school. They may present as very confrontational, defiant, saying things that are counterproductive to what's happening in class or at a job. Will, in a college setting, maybe challenging a professor, and that comes across as an autism characteristic. But if it's persistent, then it becomes potentially a diagnosable mental health condition. Some of the risk factors to obtaining a second diagnosis are genetic conditions such as Fragile X or Prader-Willi syndrome, medical conditions, seizure disorder, GI issues, family genetic factors, of course, and then psychosocial factors, whether it's socioeconomic, cultural, some trauma in past environments can certainly trigger a second diagnosis.
In fact, if we could go back to it for a second, to this whole issue of trauma, I think it's important to keep in mind that because of the impact of autism, some kids can experience trauma from everyday experiences.
Absolutely.
So, for example, if I'm a young person with autism and I don't have a good communication system to ask for food, and I get extremely hungry, and when I get extremely hungry, I feel weak and I feel overwhelmed. And if I don't have a way to ask for food and I'm feeling frequently weak and overwhelmed, I'm beginning to interpret the world as a traumatic place to live where my needs are not met. And so we can't just say there wasn't a traumatic event. We also have to look at the impact of the disorder and consider from the perspective of the individual whether or not there is trauma associated with everyday events.
Absolutely. When I think about food and autism, a lot of times there's that very rigid food selectivity, and as family members, as educators, we try to expand that, and that forcing of food or making children try new things when they really have maybe some sensory sensitivities to it or very aversive reactions can also be traumatic.
Right, exactly. So what we're talking about really is all of these diagnostic considerations, and yet we still have a person with autism who's trying to interact with a medical system. And so one of the main things that happens that acts as a barrier to an individual with autism achieving or getting a diagnosis for the purposes of getting good treatment is what we call diagnostic overshadowing. And that means really that a child already has an autism diagnosis. And so if that parent is really confused by the child's behavior and looks at other kids with autism in the parent support group or in the child's classroom and sees that their child with autism is really behaving differently even than other children with autism, they may seek help from a physician or a psychiatrist. Well, diagnostic overshadowing acts as a barrier to getting help. And that means that the doctor is likely to look at the child and say, well, they've got autism, and these are all symptoms of autism, so there's nothing else going on because this is autism. When the parent feels really lost in that whole experience, because the parent knows, I've seen other kids with autism. My child goes to school with kids with autism. I have friends who have children with autism, and yet my child looks very different, and they're getting worse. And so that is a real problem. The only reason for getting a diagnosis is to get appropriate treatment. And so if a child is coping well, is doing well in their environment, is learning if they're in school, or is able to work if they're in an employment setting, and they are doing well, there's no reason to get another diagnosis. But if a child is having extreme difficulty, if they're being kicked out of school frequently, if they are really struggling, and when you look at that child and you compare their life story, their experiences, and their responses to the environment to other children with autism, and you see a real difference, it might be that you need some other kind of treatment approach to assist that child. And so you have to look out for diagnostic overshadowing. The second area that we look at as a barrier is baseline exaggeration. And that is, you maybe have heard of the myth of the frog in boiling water. You know, if I take a frog and I put him immediately into boiling water, the frog is going to jump out because the temperature change is abrupt and distressing. And so it activates that frog's defenses. But if I have a frog, I put them in cool water and slowly turn the temperature up until it's boiling, the frog doesn't jump out, because the frog thinks that, oh, this is just a little warmer, this is just a little warmer. And that's kind of what baseline exaggeration is, that there's increases in behavior, but we keep addressing each little increase, and we don't have the ability as humans to step back and see the whole picture and see that things have really changed for this child. That before we were able to treat and provide services to the child in an inclusive setting, and the child was adjusting and coping well, and then something was a little different, maybe their teacher changed, maybe their instructional assistant in the classroom changed, there was some kind of change and the child began to display some problem behavior. Then maybe there's another change, maybe a best friend moved, or they moved and they're going to another school and there's a little bit more behavior. And maybe then there's another change. Maybe there's problems in the family, so the parents are separated. Or maybe there's a death in the family so that a primary caretaker like a grandmother has passed on. And then there's more behavior. We see those challenges increasing over time, and we don't link them together as a possible diagnosis. And so we just think, oh, it's always been this way, because we're like the frog who was in the cool water and then the water eventually began to boil. And we've lost track of the overall acceleration or increase in these behavioral challenges. And then finally, unfortunately, there are significant discrepancies that are related to culture and social economic status. And so consequently, individuals of different culture or individuals who experience poverty are less likely to have access to the best diagnostic and treatment resources that there are. And so it might be that for those individuals, we're not able to get them to good treatment services or good diagnostic services just because of their situation. And that's unfortunate. I mean, that is really a bit of a real problem that we have to address from a cultural standpoint.
I've also seen with the cultural aspect that it's attributed to the culture that they're acting in a certain way, or because they're from a lower SES, maybe those behaviors are because that's the way it is in that culture or that environment.
Yeah. So again, that diagnostic overshadowing kind of
Right.
attaches there as well. A lot of times when we talk about mental health diagnoses, we think medication. If you have a diagnosis of depression, we have this drug called an antidepressant. And how handy that is that here's depression, here's the medication that makes it go away. That's not how medication works, but that we sometimes think that way. You have anxiety. Well, here's an anti-anxiety medicine. How handy that we have the antidote to anxiety. It's not quite that neat. And so what happens is if a child or an adult with autism has a diagnosed mental health or psychiatric condition, and there's a known medication for that, they may get that medication. So if a child has the diagnosis of depression, there might be an attempt to try different antidepressants to address that depression. However, for individuals who have less ability to communicate or who have more impact from both their autism and their co-occurring disorder, we might see the other, which is we see behaviors, and the behaviors are becoming increasingly severe. And so without having an exact diagnosis, we attempt medications to change the behavioral pattern. The problem with this approach to using medication is that we really have to test that, because at that point we're operating on hypothesis. We really have to understand what we expect to see, how long we should wait, what are the side effects of the medication, how will that medication impact other environments. And so if you see a child who's struggling with anxiety and you attempt an anti-anxiety medication, you might need to be aware of the fact that this might make the child sleepy at school. Or suddenly you're trying to decrease anxiety so they can be more included in the community, but they're taking a drug that decreases their ability to be included in the community. And so you really have to be careful with medication. I'm not saying don't try it. There are medications that are very effective and really can help children and adults with ASD. But we have to treat medication with a strong skepticism about its effect. And we really have to continue, as Staci said earlier, to take data and to make sure that whatever treatment approach we're attempting is making a difference in the life of the child. Any treatment that we attempt should really result in an increase in quality of life and not a decrease in quality of life. And that's one of the dangers with medication, is we might get an elimination of symptoms, but we might also get an elimination of quality of life.
That's a very good point.
So with this whole psychiatric diagnosis versus behavioral hypotheses, people with less cognitive impairment, those who had the syndrome formerly known as Asperger's, people who maybe have more verbal abilities, generally can get a diagnosis. But people with more significant cognitive impairment or more difficulty engaging in any kind of insightful or discussive therapy might actually get a behavioral hypothesis. In other words, we're trying to treat behaviors rather than stepping back and asking questions about the overall health of the individual. As I talk about this, I think to myself about the board-certified behavior analysts who might be watching right now. And as you know, if you're coming at your frame of providing services to individuals with autism from that behavioral perspective, you might be listening and saying there is no such thing as depression or anxiety or obsessive compulsive disorder. Well, I want to remind you that we now have research that actually points to different chemical and biological responses in the brain to events that actually now we refer to as depression and anxiety. At some point in our diagnostic profiles, we might be able to have blood tests that would indicate whether or not a person has an effective serotonin system that works for their body and keeps them from experiencing depression. But we're not at that point. Yet we know serotonin is very, very much involved in depression, anxiety, and even sometimes in obsessive compulsive disorder. And so for those BCBAs out there who are saying psychiatric diagnoses don't exist, I want to remind you that we now have a lot of biological evidence, and we also have a lot of genetic research to support the idea that not only do these disorders exist, but they tend to run in families.
Right. And so family history is really important.
Right.
And I'm so glad you brought this up because it really speaks to if we see those differences in behavior and behavioral interventions aren't working and they seem very off from the normal of this child or adult, then we really need to consider, is there a neurochemical difference? And if we address it with medication, appropriate medication, and we see a change in behavior, then that's appropriate and that's what's needed. So it can't be a behavior intervention that's going to take care of it all.
Right, right. That's exactly the point, that we want to layer treatment that makes sense for the individual. So it's difficult to diagnose purely based on behavior, and yet that's very often what we're left with. But we also have to consider external factors. Sometimes there are known events. Sometimes people experience a loss. And very often, people who have experienced a loss in their families, important people to them, are grieving. We have to remember that people with disabilities frequently experience loss that we don't take into account. Like if an individual is living in a group home, or attends some kind of day support service, and a favored staff member gets another job and leaves. We might view that as an everyday experience because that person had a job and they got another job. But from the perspective of the person with the disability, that's a loss that they may need to grieve. They had somebody who they depended on, who helped them live their lives successfully, and who really helped them be successful individuals. And by losing them, they have experienced the same loss as a death. And so we have to remember that there are external factors that influence individuals with disabilities, and we have to take account of them and consider them from the individual's perspective.
This reminds me of an example. There's a gentleman at a day support program who, it was every Sunday, his mother would come and visit. And she'd spend a couple hours with him and they would do things together. She'd talk to him, they'd play a game. Well, she stopped coming. And the staff noticed a change in his behavior and they couldn't quite figure it out. Well, because she stopped coming, because she was in the hospital and no one told him. And they assumed that because he had minimal language that he wouldn't understand. And so making sure that we take the time to explain what has happened, to help a person go through the grieving process is important.
There's actually a woman in the Richmond area here where we're recording this webcast who does work with individuals with autism around grief and who really helps service providers and families consider grieving as a part of the overall human experience that individuals with autism also experience. We also have to be aware that when we're using treatment that is behavior specific rather than diagnosis specific, we might be having different treatment goals. Anybody who's experienced depression knows that there is a management strategy that you have to have. This is a biochemical experience. Your body is not responding to serotonin or epinephrine in the way that it formerly did. And so consequently, you have to learn, if you're struggling with depression, how to manage your view, how to engage in activities and behaviors that will make you feel better, how to help yourself cope on the lowest of low days. And so we might alter our treatment strategy based on diagnoses. And so the example that I have on the screen I think is apt. Decreasing aggression is one strategy, but it is also a strategy to talk about managing depression, that our treatment approach, that our activities that we might engage in might look different if our goal is only to decrease aggression versus teaching someone to manage their own depression. So what you see is the impact of these comorbid or co-occurring diagnoses really does change the way we view things. So I like to use this example of the iceberg. We see the tip of the iceberg, which might be the behavior. And so I actually worked with a team just yesterday where they're seeing a lot of increases in behaviors that include throwing items at work, swiping at or swatting at people to get away from this young individual. We see this individual is working very much slower, is resistant to engaging with the environment. So we see all of these behaviors that are different from what we previously saw. Underneath that, what we might be missing is that he's experiencing a lot of anxiety. He happens to be someone who really desires everything to be very much the same. And he just went through a change at home. He happens to have allergies that are creating changes in his behavior. At work, he has a lot more congestion, and that's really changing the way he responds to his environment, which is actually triggering a lot of these anxiety reactions. And so we really have to be aware of this whole idea of the iceberg, that what we see is the behavior, but we have to look underneath the water to figure out what's going on. If we miss that iceberg, if we miss the bottom, and if we only focus on the behavior, we might treat and educate that individual ineffectively. We might miss the meaning of the behavior before us. If somebody is experiencing anxiety due to congestion and changes in their home and work status, what we might miss is that this individual is really very anxious. And whereas we might be responding to the behavior, we really need to respond to the bigger picture that's going on. We might actually end up suppressing very important and meaningful messages to the individual, and therefore we become ineffective. Finally, this is one of our greatest challenges as educators. And when we educate, we expect to see children get better at what it is we're teaching them to do. We expect to see them increase their skills and abilities. But mental health challenges are actually cyclic. We see people doing very well for a while, and then either because of what's happening internally, biochemically, or because of some external event that influences their overall view of their world, we see them cope less well to the same challenges that they faced very well previously. And so we really need to be aware of that. So maybe instead of thinking about graphs, we really need to think about how do we support and surround people with individuals who understand everything that the person is encountering. So, for example, we might see someone who struggles with anxiety and depression, and they also have autism. So we need autistic individuals in their lives who understand autism. In the graph before you, this is a social map, and we might have a picture of the individual in the middle. That's the individual with the yellow circle around them. The people to the right might be that individual's family members. And those people to the right that you see before you right now might be individuals who provide a tremendous amount of support. Or if you see the gentleman immediately to the right, and then off of him there's another individual, that might be somebody who supports the family to support the individual. The individuals in the red triangle of circles in the lower left-hand corner, those individuals might be autism experts, and they might really assist that individual in understanding and providing supports around autism. The individuals up and to the left might be folks who really understand the mental health diagnoses. These social maps can really help us understand how do we support someone with autism. Rather than thinking of it continually getting better, maybe we need to think about what is the expertise we need available to the team to support the individual through their ups and their downs.
What a holistic way of thinking about putting the person in the center and thinking about all those people who come in contact with them, who will have that information about the person's behavior, their mood, and so forth, and the appropriate people there to treat and work together for the best treatment plan.
Exactly. So Paul Shattuck out of Drexel University talks about social dynamics and social maps all the time, that we need to, for individuals with autism, not just think about the child, but also the family. Maybe the mom is the primary caretaker. And so we don't need just supports around the child, but we also need supports around the mom. And if we were to draw these social maps for these individuals with autism who might have fairly complicated behavioral profiles and diagnoses beyond autism, we really need to think about how do we best support them. We also need to think about diagnosis and diagnostic tools. Now, as I show these tools on the screen, these are not the only tools, so please don't leave this webcast thinking, I better go buy these ones.
No.
But these are some tools that have been found to be effective in identifying secondary or co-occurring diagnoses in individuals with autism. That said, we also need better tools. And none of these paper and pencil tools can replace good clinical observation. So you have to go beyond self or parent reports. You have to look at behavioral indicators, but you also really have to be careful about those family histories and those individual histories. They make a huge difference as well. We're going to really spend most of our time in this webcast talking about the non-pharmacologic treatments, because we assume that our audience is mainly educators who actually don't have access to a pharmacy. I don't know of a high school in America that has a pharmacist on call who you can say, hey, Johnny's got some behaviors, bring over the happy pills, and all is fixed.
If only.
If only. So, we really do talk about behavioral interventions. And so when we talk about behavioral interventions, we really have to understand that if medication is being used, it is not a fix-all. Medication is more like opening a window a little bit. In order to continue that fresh air coming in, we've got to do the behavioral work to push that window a little further open to allow those educational strategies to work. And so let's talk first about behavioral interventions for anxiety. First of all, we have to really understand the anxiety pattern. And so this gets back to our board-certified behavior analysts who know how to complete functional behavior assessments and really look at those triggers or antecedents to the anxiety reaction. We have to understand that what the behaviors are that are associated with the anxiety reaction. And we have to really also understand the average amount of time that the individual experiences an anxiety reaction. If we see someone kind of going into a panic or a true anxiety reaction, and we know that that lasts about 15 minutes, it really does help everyone around that child know what to expect and how to assist the child, and also to judge whether this is a really exceptionally difficult reaction. So if that reaction goes on 20, 25, 30 minutes, we know that maybe we need to call a parent or get additional help.
That operational definition of the behavior is so important so that everyone is aware of what the criteria is, so that we know that if there is something that's not quite right or that there's an additional component of that behavior, we do ask for additional support.
Exactly. We also have to understand what are the calming strategies that make a difference. You can't wish anxiety away. You can't reinforce it away. You can't punish it away. If you yourself have experienced anxiety, and if you know what it's like in that moment where your heart is racing, your brain is not thinking clearly, you are not responding to a situation rationally, what you understand at that moment is no amount of rational talk is going to change your reaction. And so instead of using all of those strategies that try to suppress that behavior, what we really need when we see a child who has a true panic reaction is calming strategies. It seems counterintuitive, and it is also important, as Staci pointed out, to know what's a child try. What does it look like when this child tries to manipulate me? And what does it look like when they are truly in a full panic reaction? That's very important information because we might respond to those events differently.
And the calming strategies in that crisis mode is not the time to teach them.
Right.
So these calming strategies need to be taught prior to any sort of panic episode or anxiety behavior.
Yeah. I frequently use the example of literally trying to teach somebody to swim while they're drowning.
Right.
Imagine you're drowning and you're struggling, and somebody says, okay, now go to the side, push your arms around, pull yourself forward. That's not the time to teach swimming. So some of the ways that we address anxiety is through sensory integration methods to lower the general level of anxiety. And that might be those good old-fashioned things that we all engage in, a really vigorous walk where we maybe get our heart rates up, which would also increase access to endorphins and serotonin. We might pre-teach the person themselves how to identify their own triggers for anxiety. We might try relaxation training, and relaxation training is a really good strategy to, again, lower the temperature. What we know about individuals who have anxiety disorders is their overall alertness is activated. It's higher than the general population. So I might walk into a room and I might think, gray walls. But if I have an anxiety disorder and if I am fearful of an event that happened in a room with gray walls, the presence of gray walls might actually trigger me and bring me a little higher. And so one of the things that we could do is to try to turn that activation back through relaxation. We have found that visual support, when using systematic desensitization, really helps. And systematic desensitization is very gentle, very gradual exposure to the anxiety-producing event or item. And we have to be careful about using systematic desensitization. But if we use visual support and if we give the individual control of when that session stops, we find that they do a little better. We also want to avoid anxiety triggers. If yelling is a trigger that creates a response in somebody, we really don't want to yell at them. I mean, it's sometimes that simple. And then we also have to teach the person how to manage their own anxiety. There are lots of tools that you can learn to manage your own anxiety. For those individuals who have the ability to talk to themselves, self-talk is very effective for managing anxiety. We also want to think about family intervention here. Anxiety and depression appear biochemically to be two sides of the same coin. They're very closely linked. So frequently, if someone has an anxiety disorder, you might also find that they struggle with depression. Likewise, if somebody has anxiety in the family, it's very frequently the case that other family members also have anxiety. And so what we want to be aware of are the symptoms of anxiety. We want to teach the family how to manage that reaction, because if we know that anxiety is a familial trait, and if we know that somebody has extreme difficulty with anxiety, we might be actually seeing anxiety feed on each other. So the child responds with a panic attack, which might trigger mom or dad's panic, which might trigger other children in the family's panic, which further feeds the panic. We might have a big old panic reaction happening in the entire family. And so one of the things that we have to be aware of is really how to help that family implement the behavioral intervention, manage the anxiety reaction without triggering their own anxiety, using social stories and other visual supports, and really helping that family address those needs. Another technique that we frequently use is cognitive behavior therapy. And we actually have a case that we're going to talk about momentarily where we talk about how we use cognitive behavior therapy. This is an excellent strategy for schools because this actually capitalizes on teachers and educators' strengths in teaching. We actually, in cognitive behavior therapy, are teaching individuals to recognize their own triggers and respond differently. And so we look for individuals who are able to collect their own data. We can go into the next slide. We also help individuals engage in the whole process of reporting, problem solving, setting goals, and realizing the connection between their behavior and their own self-identified quality of life. That's really the basic crux of CBT. So this is based on assessment. We identify the behavior that we're concerned about that is as a result of the psychiatric or psychological diagnoses. We identify the cognition behind that behavior. So I'm going to use my gray room example again. And maybe I have a child who associates gray room with being yelled at and failing. And so the minute they come into a room with gray walls, they become very anxious and they immediately think, I'm going to fail in here and somebody's going to yell at me. Well, part of what we want to do is we want to understand that cognition so we can help that individual flip that script.
Yep.
So we also work on baseline data that the person themselves completes. We complete an FBA, we develop a hypothesis, and then we engage the individual in planning. And that includes what strategies will work for you, what fits with you as an individual that you really want to attempt. What are your goals and what is the target of your goals? How do you want to change the beliefs that are antecedent to the problem behavior? And what we want to do is build new schemas. And so I have some examples of maladaptive schemas. And so on the slide before you, what you see is a schema that says there's an antecedent, and maybe that antecedent is a difficult task. There's a thought before that individual behaves. And the thought might be, my parents will be angry if I fail, and I'm really fearful of my parents' anger. My behavior then is I'm going to yell and scream and hyperventilate to avoid the task, but also avoid failure. With cognitive behavior therapy, we're really going to target that thought as well as the behavior that follows. And so in the adaptive schema, we see that we introduce a difficult task. We really work with the individual to understand that trying does not equal failure and mistakes are okay. And then we teach the individual to try self-control. And in this case, self-control might be relaxation. It might be positive statements that I engage in. And then finally, we achieve the same function, which is you still get to avoid failure because the focus is on trying and not on 100% success. And so I have a case for you. This young person, we'll call her Amy. She had extreme difficulty at work. Specifically, she made a lot of sarcastic comments. It won't surprise you to know that she fell on the syndrome formerly known as Asperger's or the quote higher functioning end of the autism spectrum. The kind of sarcastic comments that she would make would be seemed rude at times. If somebody else made a mistake in her environment, she would say, well, of course you made a mistake. You're always making mistakes. Kind of a sarcastic comment pointing out somebody else's errors is not very helpful. She would also cry at work. Like there's no crying in baseball, there's no crying at work. I mean, think about it. And her crying was pretty consistent and pretty frequent. 5 times a week, at least once daily, she would cry at work. And then she would argue with coworkers. And you can imagine if these sarcastic comments are happening 2 and 3 times a day, her coworkers are arguing back. And at least twice weekly, she would get into arguments. Now, we had a profile in this one person of 2 workers. She was dedicated. She was there every day. Her work was thorough. Her work was accurate. And she was fast. Excellent worker. On the other side, she argued with her coworkers, she was sarcastic, she cried at work, she refused to engage with others if she perceived that they were mad at them. Terrible worker. So she was the perfect and horrid worker at the same time. And so we completed an FBA to try to figure out what was going on. This involved interviewing Amy, interviewing her job coach, and we actually had Amy collect her own data. Staci is now really going to describe the intervention that we implemented.
So with Amy and her sarcastic comments, because she was able to kind of be self-aware and retrospectively think about what she said and how that could have maybe caused her coworkers to be a little bit upset with her, she was able to learn some scripted interactions. So instead of saying those very sarcastic comments to her coworkers, when she was going to interact with them, there was scripted things that she would say. And she would practice those with her job coach. Occasionally she'd get off on some of the nuances of what she was supposed to say, but the job coach was there to say, remember, we're having a polite conversation. That's what you need to do at work. This is how you're going to keep your job. Because ultimately, those horrid behaviors are the things that are going to get her fired. And employers aren't going to look at the wonderful work that she does do. So after that, we would review the episodes. So whenever there was an interaction with a coworker that wasn't quite appropriate, she would be sat down with and talked about, okay, so this is what's happened. This is what you said to the person. How do you think they felt? So really trying to focus on their perspective taking and understanding that perhaps that person is not going to want to be your friend, want to work with you, may even call your supervisor because of your behavior. They talked about possible motives. So the scales of justice game. Why don't you describe this one? I like the way you describe it.
It is a great idea for a person like Amy. We would literally draw a scale, a weighing scale, the old-fashioned scale where you put some weights on one side, you put some weights on the other side. And I would say, okay, so she called you stupid for calling her wrong, right? And I would say, that's really bad, because this is some of the conversation with Amy. She would argue, but she called me stupid. And I would say, yeah, that's bad. So I'm going to give her 1X on her side of the scale. What did you do in response? Well, I told her that she was ugly and she didn't deserve a job. And I would say, oh, well, that's pretty offensive. Let's give you an X. Then what did she do? Well, she said that I shouldn't be talking to her like that. And I said, well, that's fair. You shouldn't talk to her like that, so she doesn't get an X. What did you do? Well, I told her I was going to talk any way I wanted, whenever I wanted, because I was right. That's pretty rude. You get another X. In other words, we kind of kept on going back and forth, reviewing an episode until Amy saw on paper before her that she had many more X's than her coworker, so that she could really reflect, I guess my behavior did get a little out of hand there.
Another thing that would work with someone like Amy is, how big is the problem?
Yes.
So sometimes folks with autism consider their problem to be the biggest problem ever, and it's actually just that's like a little bump in the road. So giving visual supports around how big is the problem and what you'll do if it is a huge problem, a little problem, or not even worth talking about. And so teaching her those strategies would be helpful as well. Rehearsal methods, of course, role-playing and reverse role-play is very important. The more you practice, the better you get at things. And especially for Amy, she got much better as she practiced with her teacher, her job coach. And then when she'd go into the work setting, it would be just easier because she was practicing the right way to interact with people.
It also provided the job coach an opportunity to be able to cue her to demonstrate this behavior a little easier. So instead of having to role play right there how to accept correction, you could say, Amy, do you remember accepting correction? And she was fine.
The other thing that we do a lot of is social autopsy. Mm-hmm. And that's really looking at what is the social consequence of the behavior and what can you do to change it in the future and what to do to change it right at that moment, because her calling her coworker stupid or ugly or whatever is very detrimental to her job and to the social interaction with her coworker. So what is she going to do to make that wrong right? And the social autopsy will help her kind of map that out so that she's able to do that. And then she goes ahead and redoes the interaction, like a do-over, so that she has the opportunity to make the wrong interaction right, and so that the coworkers can actually see that maybe it's not so bad. So we have to look at what the desired behavior is, and it's important to make sure that you have that definition in place. So in place of her comments, what is the replacement behavior for that? We want her to request her coworkers to wait. So they want her to go faster, or they want her to move along, or what have you. Well, instead of her saying stop it or something inappropriate, we'd rather her say, can you wait a second? Or I'll get right there. So it's much more acceptable and much more appropriate. Like Carol said, crying at work is really kind of difficult. So instead of crying on the spot at work, she can excuse herself, maybe take a few minutes to take some deep breaths, get a cup of water, and then ask for an email follow-up. So whatever the person was trying to say, maybe they can send it in an email instead of having that interaction right there, because that face-to-face interaction can really cause some of the social struggles. Folks with autism have that facial recognition issue, not understanding their body language. So if that increases that anxiety, having an email that they can read back, can talk to their job coach about, hey, what does this email mean, would be appropriate. And so in place of arguments, because arguing at work is also inappropriate, again, excusing herself from the interaction, and talking with her job coach about, I really feel like I was being bullied. I mean, she's making me do these things and making me do my work, and I don't like it. Well, and in fact, she wasn't being bullied. She was just being told what her list of activities for the job was. And so identifying with her, that's not a big problem. She was just trying to help you, and having her kind of step back from the situation and do that perspective taking. Self-reinforcement and self-evaluation is really important. We always look to external reinforcers, and as you get older, you don't always have those external reinforcers. So really thinking to yourself, okay, I did a really good job here. I got my work done. I didn't get into any arguments with my coworkers. I'm really busy. My boss is really proud of me. I'm doing a great job. Having that is golden, and that will keep her motivated to continue that appropriate behavior at work. So really having her have that script of the good things that she's doing and that self-actualization. So the outcomes, she was employed for the longest period of her life. So really looking at those behaviors that could have caused her to lose her job immediately, we addressed those, and she was able to be employed. She actually developed some friendships at work. So some of the people that were kind of rubbing her the wrong way, she actually went shopping with. And so those friendships, emerged. And she was comfortable enough to eventually tell her coworkers about her disability, which, I think is really important, that self-disclosure at a person's own time to their colleagues, their peers, so that their colleagues understand. They may have well known that there was something different about her, but her saying, this is me, this is what's going on, made her feel really good. And we saw an extreme reduction in problem behaviors. So that was awesome. Mm-hmm. So people with ASD use cognitive behavior therapy to address anxiety disorders. But you can't that's very abstract. And we know that, changing schemas and changing thought patterns is a wonderful tool, but you have to have the visual supports to go with it. Just being able to say, oh, you know what, I'm not going to think that this gray room is going to cause me anxiety is going to be very challenging. So having the visual supports ahead of time, maybe some social stories, you're going to be going into a gray room, but there's nothing that's in there that's going to harm you. You're going to do great at what your task is. I'm proud of you. Your parents are going to be proud of you. Just having those social narratives to help change that thought pattern will certainly help with CBT. Again, visual strategies. It's like our mantra. Visual strategies. So making sure that as professionals, you provide those for people. And even when you think that they don't need them anymore, have them there, because you never know if there's that very anxiety-provoking event. Having the visual support to go back to will ease that that anxiety much quicker than trying to talk a person through it. Self-management and brief exposure to the events and environments. We talked about that systematic desensitization. That's very very effective. But again, we really want to make sure that we're doing that based on the comfort level of the individual. So you wouldn't want to say, we're going into this gray room and I'm going to close the door and leave you. We might open the door and look in. Oh, it's a gray room. Nothing's bothering me here, and then leave. So that gradual desensitization. And then systematic movement toward a normalization of environment. So don't get too comfortable. Keep moving toward normalized environment. So you don't want them to make every room that's gray be so traumatic, but more of, oh, it's a gray room, I can deal with it. Because imagine the number of gray rooms in a person's life. So if we address it right away, hopefully that'll generalize to all environments that may have gray rooms.
Well, and I think the other thing here is a tip for folks who are providing supports.
Right.
So often we get a reduction in problem behavior that we actually think, oh, we've arrived.
Cured.
Problem behavior's gone. But what we forget is that this individual will continue to grow and develop. And so if you're serving children in an elementary school and you have a behavior problem that you address successfully, and maybe that behavior problem is due to some kind of co-occurring diagnoses or disorder, don't think that oh, we've gotten rid of the problem behavior, we don't have to do anything else. In fact, that child is going to go to middle school, and that middle schooler is going to go to high school, and that high schooler is going to go to work. And so we have to keep thinking ahead and remember that what we want for our individuals with autism is the fullness of what life has to offer.
Right.
And so it's not just reducing the problem behavior, but it's actually moving toward that normalized environment.
Right, and knowing that in middle school there may be new and different triggers of anxiety or depression, and just the onset of puberty itself can cause some of those increases in those behaviors and diagnoses. So making sure that we are one step ahead is a really important point.
Yeah. This last slide with the real meat of the presentation is about sleep disorders. So many of our individuals with ASD have sleep disorders. And in addition, sleep disorders are also associated with anxiety, depression, and a form of anxiety disorder, obsessive compulsive disorder. And so Mark Durand wrote a book called Sleep Better. It's a tiny little book, and it's very helpful in helping you target your sleep intervention to the type of sleep problem you're viewing. So for example, there's a different strategy for teaching someone to get to sleep than staying asleep. And inevitably, most people have some period of slight wakefulness in the middle of the night. So teaching the person to fall back to sleep requires a different strategy than waking early. And so I really do recommend Mark Durand's book to really assist you in thinking through what kind of sleep problem are we having and how do we address that problem in this. Yes, it really is. I think I've given away more copies than I own.
It's been around forever, and
yes.
It's by far one of the best.
Yes. There are also in Virginia the REACH teams. Each health planning district has a REACH, or a Regional Educational Assessment Crisis Response and Habilitation team. This is for children and adults, and it is meant to assist individuals who have a developmental disability like ASD, as well as a mental health challenge. So this is a really good resource for those in Virginia who are seeking help for children or adults with ASD who are also having co-occurring mental health challenges. We also have a number of print resources that we wanted to highlight. And Staci is pulling up our screen to show you One of my favorite books is the one before you right now. It's called Treatments That Work, written by Peter E. Nathan and Jack M. Gorman. This book, I actually said to Stacy, should I bring it over? It's thick. It's not really a big book, but it's a very thick book. And so we decided to show it on Amazon.com. You can see it's a little pricey at $78, but if you're providing supports to individuals with autism and co-occurring disorders, this is really going to address the co-occurring disorders. It's going to describe CBT in great detail. It's going to describe how do we use dialectical behavioral therapy for individuals who have personality disorders and some other of the challenges that we see. Another book that is not quite as expensive and not quite as big, but is also equally good, is Treatments That Work with Children. Again, this addresses treatments for the major occurring childhood diagnoses. So you will see a whole section on anxiety disorders, a whole section on depression, on behavioral disorders, etc. This book really takes those strategies from a child perspective. There are not a lot of books that are specific to co-occurring disorders in individuals with autism. However, good colleagues of ours out of Virginia Tech, Angela Scarpa, along with Susan Williams White, in collaboration with Tony Atwood, wrote a book on cognitive behavior therapy for children and adolescents with high-functioning autism spectrum disorder. And so if you're really providing services to that spectrum, this might be a good book for you as well. So our take-home messages really are to assess, to correctly diagnose the problem, to understand that our goal is to understand what's happening with the child. Let's treat with the lowest risk method, decrease the problem, minimize unwanted side effects, and thereby increase quality of life. These are all the goals of successful treatment. And so what does that mean? It means that we really have to work hard to get good diagnostic services. Our plan has to be based on hypothesis, and we have to use data to confirm those hypotheses. We have to really implement with treatment fidelity. Stacy and I will tell you there's nothing more frustrating in providing support to teams than going into a situation and hearing a teacher say, oh, I tried that once. On Thursday afternoon between 2 and 3, it didn't work. Well, that's not quite treatment fidelity. That's not even a trial. That is a minimal attempt. And so treatment fidelity means that if we're going to try CBT, we're going to try it for a month before we determine, based on data, whether or not it's worked.
And if it didn't work when they were 5 years old, it might work when they're 15. So, really consider that going back to other treatments might be appropriate.
This also ties into ongoing data analysis, and it's really important for all of our teachers, for all of our service providers, for everyone who provides services to these children with autism and co-occurring disorders to learn how to collect data that gives you good information about what's happening. It's really hard to take a stack of paper and say, here's my data, figure it out. So we've got to get to the point where we understand how to analyze data, and we understand really how to use that data to inform our treatment. I think there are other webcasts that will address data collection.
Yeah, go ahead.
Go ahead.
Just a quick anecdote about data collection. It is springtime in Virginia, and allergies are very high. And I worked with a young man who, in about March, we would see an increase in behaviors. And in September, we'd see an increase in behaviors every year. And by the third year, we realized it was allergies. And so we will give him allergy medicine prior to March starting and prior to September starting. And we saw a great reduction in behavior. And that was because of data collection.
Honestly, it makes a huge difference in your life if you can go back and if you can look a couple of years and see patterns like that. Finally, revise. We have to revise these plans for individuals with complex behaviors, with co-occurring diagnoses. We always have to revise because what triggers anxiety as a 5-year-old versus a 15-year-old changes over time. And so these are individuals that we really have to stay on top of.
Carol, this was really great presenting with you today and on a very important topic. Thank you so much for listening.